Now, before we even start this video, the best advice I can give you to start consulting better with kids is to actually have kids. Getting a sense of what is normal at different age groups as you watch your kids grow is super useful. And then finally, when it comes down to the examination, knowing how to handle a baby or to handle a kid becomes much easier when you've already done that with your own children. And you're not worried about actually breaking the child that you're examining. And so if you've always been on the fence about whether to have kids or not, well, feel free to pause this video and come back when you're ready. The 3 tips that I want to concentrate on in this video is number 1, a resource tip. Number 2 is a clinical system tip. And number 3 is a communication tip. And I have created a video called the 7 internet tabs that you open as a GP. And within that is a completely free resource that I will often use when I'm consulting with pediatric patients. And that is the Royal Children's Hospital. Now, I'm currently working in Australia, and even when I was working in the UK, we were still using these guidelines because they are really well written. Now, just bear in mind that some of these guidelines will drift into the remit of secondary care. Some of these recommendations are a little bit more advanced, so just bear that in mind. Now, this is the website. You go down to health professionals, and you basically just click on clinical practice guidelines. Now, I'll be honest, the search function isn't so great, so you will have to choose the guidelines that you are interested in. And as far as I'm concerned, one of the guidelines that I use really often is the constipation guidelines. And why I find this really useful is that constipation is just such a common presenting complaint. There will typically be 3 times where kids go through a constipation phase that is not pathological, that is not sinister in any way. The first phase that I've noticed is weaning, the second phase is potty training, and the third phase is when they go into some kind of schooling system and they're either scared or disgusted of the toilets. Let's be honest, we've all been there, so no judgment here. Why I find this is really important is because it has the disimpaction management. Now, sometimes if kids are constipated or there's overflow, and one of my patients actually called it paradoxical constipation. I don't know if that's a thing, but it does make perfect sense. You need to be very clear and instruct parent on how to give these laxatives. And what I will often do is I will basically just highlight this whole bit and just copy and paste it into a Word document and print it out for them. So what this basically means is the child is getting the right amount of sachets on the right days and is getting the amount that is appropriate to their age. I will often see kids that are a little bit older and they're basically using tiny doses of pediatric Movicol, for instance, and it's kind of quote unquote not working. So this is great to help with that. And I find these guidelines are also great when we're talking about penis conditions. We used to use these guidelines in the UK, the penis and the foreskin. This is absolutely brilliant. And it will cover all of the major things that you are thinking about here, especially when we're talking about phimosis, paraphimosis, zipper injuries. This definitely isn't something that I'm going to be managing in GP, at least at this stage in my career. But yeah, here we go. So you'll pretty much be wanting to use wire cutters here. Oh, there's actually a little picture. I'll probably blur that one out for you. Now, another guideline that I will often look at is the molluscum guideline. Such a common condition in kids. And for GPs, it's really easy to diagnose and it's really easy to give advice about treatment, which is pretty much don't do anything, it'll go away without any scarring. But that can be a little bit tricky when the lesions are a little bit more widespread. There are a few pictures here of what this looks like, and there's some advice here about management. What you can basically do is turn the screen and you can go through the guidelines with the parent and just kind of explain that most children actually do not require any treatment and there's no exclusion from daycare or school that is required. The second thing that I want to show you that I think is pretty cool are growth charts. EMIS actually has growth charts. I do have to bring up a real patient, so I'm going to try to blur out their identifiable details. But if I go into consultations and they are a child, on the right hand side, growth charts have appeared. So if I click on growth charts, it will give me an idea of how they're tracking. That is super useful. If you have a lot of consultations, coughs and colds, so a great example is nursery school syndrome, where for about a year, kids build up their immunity and they have constant coughs and colds. You can be reassured. Obviously, I'm generalizing here and this isn't clinical advice, but by and large, if their growth is tracking their centiles or they're even going higher, then this child is healthy. They're just building up their immunity. If they start dropping centiles, especially 2 or more, well, then that's generally a referral to peds. They may need some blood tests and that kind of thing. Growth charts. Those are really cool things in EMIS. Now, the last tip I want to share with you is a communication skills tip. And this might not be relevant if you're a bit more advanced in your career and you're very comfortable dealing with pediatric patients. But if you are a medical student or a young GP and you're just starting out and you're in a situation where your pediatric consultations will often end in kids screaming and trying to kick you as you're examining their throat, this might be actually pretty useful for you. The difficult thing with this consultation technique is that you need to get over yourself. If you use this, it will make you feel super self-conscious, but I guarantee that 90% of your consultations after using this technique generally go okay. There will always be that consultation where it just doesn't work out, where the child is just screaming down the room, where there's nothing that you can do about that. You just do your limited assessment. So how this basically works is that the parent and the child come in and they sit down. I will fully concentrate on the parent and let them essentially exhaust their history. At this stage, the parent can take the child, pop it onto their lap. And then what I will do is I will actually bend down, look directly at the child and address the child directly. And I will even do this if the child is nonverbal. And what I mean by that is that they're really young. And I will basically address them by their first name and say, right, Patty, so your mommy is telling me that you've had a bit of a sore throat. I'm sorry to hear about that. Is it okay if we check you over? And I'll basically nod for them, and then they will start nodding. And then every time I'm doing a part of the examination, I'm speaking to the child directly, and I will often do the examination bit on myself first. So I'll take the thermometer, put it into my ear, make it make that beeping noise, and then see, well, let's see if you can hear that beeping noise. Same thing when I'm auscultating a child. I will auscultate myself first, auscultate them, auscultate myself, auscultate them. When I'm doing an ear examination, I will literally put the otoscope into my ear, and I'll bring my ear up to the child so that they can have a look into my ear. And I find that that works really, really well. And so essentially, if you do give it a try, again, at first, it is a little bit embarrassing. If you are directly addressing nonverbal children, you will get some dodgy stares from the parents. But once the examination goes really well, it's often very satisfying to hear a comment along the lines of, "Oh, Patty, you're so well behaved today with the doctor." So I hope those 3 tips make sense. So just to recap here, the 3 tips are: number 1, a resource tip, and that is the Royal Children's Hospital. Number 2 is a clinical systems tip, and that is the sent out charts. And number 3 is a communication skills tip, so addressing the child directly, even if they are nonverbal. I hope that was useful, and good luck.